Good morning. I'm Dr. Robin Pinto, cardiologist Mumbai, and welcome to CSI TV 2018, a new initiative of CSI 2018. It is my honor and proud privilege to introduce and chat with Professor Nanda, supreme echocardiographer. Dr. Nanda needs no introduction to all of us, being a world-renowned figure, and has been responsible for popularizing this field even in India. Throughout his illustrious career, he has received numerous awards, accolades, and recently the Lifetime Achievement Award from the American Society of Echocardiography, the first Indian to receive such an award. He has innumerable publications to his name and authored many textbooks, some of which we had to refer to pass our exams. He is currently Distinguished Professor of Medicine and Cardiovascular Disease at the University of Alabama, Birmingham. Good morning, Professor Nanda. Welcome to Mumbai.
Good morning.
How is it to be back in the city of Mumbai, the financial capital?
Well, it's great to be back to the home city, kind of my home city for a long time. But before I go into that, let me just say that I know Dr. Robin Pinto since he was a child because his father was my mentor, Dr. Ivan Pinto. The great guy, very kind, very hospitable cardiologist. And every now and then he will take us to his home. And at that time I met Robin, who was a small child at that time. So it goes a long way. And I'm so very glad to be interviewed by none other than his son, who is himself a very illustrious cardiologist in Mumbai. So it's really great to be back in Mumbai here. As you know, it's like a homecoming to me.
Professor Nanda, after your formative years in cardiology, you moved on to London and then to University of Rochester, upstate New York. Where did you first fall in love with the subject of echocardiography?
Well, while I was in England, actually, I got introduced to echocardiography, where they were using it mainly to check for pericardial effusion. And then when I went to Birmingham, they were also looking at the mitral valve, aortic valve, and tricuspid valves. At that time, the pulmonary valve was thought that it could not be detected by echocardiography. So that was a problem at that time. But when I was looking at some autopsies and discussing with the pathologists, very clear that most of the pulmonary valve is not under the lung, and therefore it can be imaged by echocardiography, and especially if the pulmonary artery is even slightly dilated, it will be very easy to echo. So I went and actually with my mentor also, we went and actually did some patient examinations, thought that we could find the pulmonary valve, got that validated in the cardiac catheterization laboratory using contrast echocardiography, where at that time we were using actually indocyanine green. And so then once we could see all the four valves, pediatric echocardiography was actually born, or actually took off, because we could diagnose some congenital complicated conditions like dextrotransposition of the great vessels. I thought it was something very great for me because these were kids who were blue kids, they were cyanotic kids, and most of them would die because diagnosis could not be made very easily of transposition of great vessels. So once we could do that non-invasively and make the diagnosis, then in the cardiac catheterization laboratory, the atrial septum could be enlarged, the PFO could be enlarged for better mixing, and therefore these kids survived. And then later on, of course, they had surgery, a corrective surgery for transposition of great vessels. So that was something I thought was really very good, and I got very interested in the subject. And at that point in time, I was planning to come back to Mumbai, but everyone told me to stay there because they wanted to learn from me the technique of pulmonary valve detection, and even people from Mayo Clinic came down to my laboratory to learn how to actually examine the pulmonary valve. And so that actually, that's how I permanently stayed in the United States, although that was not my intention in the beginning.
So Professor Nanda, you've seen it all. M mode, advent of 2D, spectral Doppler, color, 3D speckle. In your opinion, what was the most seminal moment for you? What you think really changed echocardiography to make it such a burgeoning field?
Well, I think first of all, I think the discovery that we could see all the four valves of the heart, including the pulmonary valve, was a very defining moment, because that's how pediatric echocardiography took birth. Actually, it was there before, but that's how it progressed. And then, of course, another defining moment came when real-time two-dimensional echocardiography was introduced, and at that time Actually, after just a few years, there was hardly any echo laboratory anywhere in the world worth its name which did not have, or any cardiology department worth its name, did not have an echocardiographic equipment. Then actually the other defining moment came when color Doppler was introduced. And actually color Doppler was introduced by me in the United States in Birmingham. And it's a very interesting story. What happened was that I'd gone to give grand rounds in Birmingham, and Dr. John Kirkland, whose books every cardiac surgeon reads and now even reads, he actually told me whether I could examine the prosthetic valves by two-dimensional echocardiography, and I said yes, we could. And at that time I'd seen the color Doppler machine in Taiwan in a very secret sort of a meeting with one of the companies in Japan who were developing color Doppler. They were not sure they should develop color Doppler or not, because that means a lot of investment, a lot of monetary investment. But I thought it was great to see the flow, blood flow in the heart. And so there are others like Dr. James Somerville, under whom I trained at the National Heart Hospital and Institute of Cardiology in London, sure not that excited, but somehow that they must have, I'm sure they asked other people also, but finally they decided to manufacture and told me. And Rochester did not have that much money to buy a color Doppler machine. So when Dr. John Kirkland, who was kind of the chief at the University of Alabama, asked me what it will take me to move from Rochester to Birmingham, I just thought quickly in my mind and said, well, if I ask for 2 color Doppler machines, maybe I'll agree to 1. I said, if you can give me 2 color Doppler machines, they're very expensive, I'll come to Birmingham. He said, done. So that's how it happened. And then when I went home, my wife asked, what about the salary? I said, I was so excited, I forgot all about asking about my salary. Okay. But luckily that turned out to be better than in Rochester, so that didn't turn out to be a problem. But for a while, my wife was very worried. There are 2 or 3 little kids, we had 3 little kids, that how we're going to survive in Birmingham just on color Doppler without any salary.
Dr. Nanda, you have many firsts in echo. You were the first to visualize the pulmonary valve, first to diagnose bicuspid aortic valve. But I'm intrigued, you thought of stress echocardiography way before it became run-of-the-mill. What made you think of stress echocardiography?
Well, actually, when I was in Rochester, we were actually doing a lot of stress testing, and we found that it was not very sensitive to detect coronary artery disease, the sensitivity being in the range of about 60%. So we thought we really have to take some other technique, and radionuclide techniques were being used at that time. So we decided, why not we actually do a stress echocardiography, treadmill exercise echocardiography with echo. So that way we'll be able to not only look at the changes in the electrocardiogram, but also look at wall motion abnormalities. And it turned out that the fellow with whom I was going to work with, he was actually from Austria, and he was a sumo wrestler. So it was very convenient, because when first of all, the chief of cardiology said that this is something he doesn't understand, doesn't think is very good, so he is not going to let anyone do his patients, but unless you yourself went and brought the patient. Now, being a sumo wrestler, very big and tall, he would actually wheel down the patients, bring them, and then when they were on the treadmill, the moment they reached the target heart rate or they could not do any further, and I was sitting with the transducer with echo machine, he would lift this patient, bring them on the bed, and immediately I could do that within a minute or so. I could look at the views that we needed. That's how it was born, and even now I think we need to immediately look at the views as soon as the exercise is completed, but that made it very, very convenient. That's how stress echocardiography, treadmill stress echocardiography as it is done now, was born somewhere about I think we published the paper in 84, 85. We never thought it'll take off, but then over the years, it took off very well. When I went to Birmingham, they told me that they hadn't heard of stress echocardiography. Of course, we were developing color Doppler machines, so they would not even permit me to have a treadmill in the echocardiography budget. Finally, one of the company representatives donated his old treadmill, which was not working very well, which he used at home for exercising himself. He brought it to the Echo Lab, donated, and that's how we started stress echocardiography in Birmingham.
Okay. You have worked alongside the great Professor Dr. Kirkland, a surgeon. What are your thoughts? Because I think to become a complete echocardiographer, the collaboration between the echocardiographer and the surgeon is extremely important. Yeah. But sometimes I feel is lacking in today's practice. Yeah. What are your thoughts on that?
No, I think that's very, very important. Of course, in the beginning, the reason we actually collaborated with Dr. John Kirkland, because whatever we did with color Doppler, we wanted to make sure that we are right. We diagnosed, for example, severe mitral regurgitation, or we saw a tumor on the mitral valve or in the left ventricle by echo, and then we wanted to make sure that we are correct. So surgery provided us the validation for many of the things that we do now with color Doppler echocardiography. At the same time, actually the surgeons, when they look at the heart is devoid of blood. So it's like a flaccid heart. They don't see the heart in motion like we all see with echocardiography. So it's very difficult for them to find defects or to even get an idea of the size of the, like for example, an atrial septal defect. So that was something where we found that the surgeons were very, very keen that we show them in the beginning so they can get a good idea exactly, how many sutures to put or what the size was. And so therefore, echo is very, very important in during cardiac surgery. And we used to do a lot, and now of course the anesthesiologists have been trained quite well, so we don't have to spend that much time in the operating room, and they're able to do a lot of things like monitor left ventricular function before and after surgery, and also help in valvular heart disease. What we now help actually in addition to cardiac surgery, now as you know, many of the interventions, structural heart interventions are done in cardiac catheterization laboratory. So we actually now spend quite a bit of time in the cardiac catheterization laboratory or hybrid laboratory where you have cardiac surgeons and interventional cardiologists working together. And echo is an essential component of any structural, abnormality that needs to be corrected in cardiac catheterization or in cardiac surgery. Is an essential component of that, of that procedure.
I'm going to ask you a funny question. In all the subspecialties of echo, I want one answer. Which is your true love? Adult, ischemic, valvular, congenital, transesophageal, stress echo? One answer.
One is a stress echocardiography.
Stress echo, okay. And why is that, sir?
Because I think you can, coronary artery disease is so rampant now, and one of the things that you can diagnose very easily or get some idea about prognosis or even diagnosis in the emergency room sometimes, stress echocardiography becomes very, very important. No radiation also.
Transesophageal echo. Again, you were a pioneer in this field. Do you feel that it's underutilized, and in the US or in India now it's increased? Do you all routinely have it in the OR room?
Yeah, it's routinely there. In the any cardiac surgery which we do, transesophageal probe is routinely there. Even in many non-cardiac surgery, like for example cirrhosis of liver and all, they would actually have the transesophageal echo on board just to monitor left ventricular function, if nothing else. Yeah, sure.
There has been an explosion of new techniques in echo over the years. After color Doppler, we've had tissue Doppler, and now the latest new kid on the block is speckle tracking. What are your thoughts? What do you think? Is there a future in this technology?
No, I think there's definitely a future, because what it does, it complements actually right now measurement of ejection fraction or LV function by two-dimensional echocardiography, because you're able to look at small groups of pixels and how they move in, how they actually move into the heart and during the cardiac cycle. So I think that is it may in future, some people feel in future it may even replace ejection fraction. I'm not sure we are at that point right now, but at least it's a very good complements a lot. For example, patients who have cancer and who are on anti-cancer medications, many of those patients actually develop cardiac toxicity, that these drugs are cardiac toxic, and by the time the ejection fraction goes down, some of that toxicity, the cardiomyopathy or the dysfunction that develops may be irreversible. So there actually the speckle tracking has become very useful, because you can detect any very early cardiotoxicity before the ejection fraction go down. So I think there are one or two very good applications. The other application, you can detect subclinical heart disease, for example, in patients with diabetes, hypertension, much better sometimes than with the echocardiography. So there is a role, already there's a very good role for speckle tracking echocardiography, and I think it's going to increase in the future.
Another interesting advance has been the use of LV opacification using these micro-engineered bubbles. Right. Do you all use this a lot in the US, or is it just taking off, or what exactly?
No, actually it's being used a lot in the United States. Before it was not being used that much, because as you know, in USA practically everyone is insured. So the insurance companies would not reimburse for the cost of this contrast echo, as we call it. But now the insurance companies are reimbursing. And if you do not see two segments, there are about 17, 18 segments of the left ventricle. If two contiguous segments are not visualized by transthoracic echocardiography, that's an indication to use contrast echocardiography. And that has helped a lot, because it's the same thing like doing a non-invasive angiogram. You can opacify the endocardium, the left ventricular cavity, and get a very good idea about the function of the heart. So that's has taken off a lot in the United States. Yeah.
Another modality I want to come to is this three-dimensional echo.
Right.
I know a lot of machines have this, but for some reason, at least in India, I see that not many doctors are well versed with this and do not utilize it in their day-to-day practice. Is it the same in the US, and what do you feel are the barriers to its global utilization,
I
as
think
it were?
it's underutilized all over, including in the United States. One of the barriers is mindset. The mindset has to change. We are so much used, for example, looking at the mitral valve, we see two lines moving and we call it the mitral valve. But if you ask an anatomist, surgeon, or pathologist, how does the mitral valve look? It doesn't look like that. So, but we are so used to looking at it. So now to change it back to something which really looks anatomical or looks pathological becomes very difficult in the mindset of all the echocardiographers. So there's a mindset problem, and I think that's being overcome slowly, but it will take some time. What has actually been overcome to a large extent in the United States is using three-dimensional echocardiography, and that's the three-dimensional transesophageal echocardiography in surgery, during surgery, and also during structural interventions in the cardiac catheterization laboratory or in the hybrid labs. But there is still underutilized as far as transthoracic echocardiography is concerned, but I think we are getting there and more people are using it. Also the reason was that it took a long time to do a three-dimensional echocardiography. Now you can use the same probe to do actually a two-dimensional echocardiogram as well as three-dimensional echocardiogram. So now it's much easier and quicker. So that was another barrier, was the time component.
Okay. I'm going to take time off from echo. I'm going to have a rapid buzzer round, and I want quick answers, no thinking. If you did not become a doctor, what would you have been?
A historian.
Historian. If not echocardiography, what subspecialty of medicine?
Probably electrophysiology or clinical cardiologist.
Your one favorite hobby?
Stamp collecting.
Philately. Oh, yeah. Very good. Your favorite type of music?
Indian music.
But pop or classical? Film song, old Hindi film songs?
Old Hindi film songs, yes.
Your favorite movie of all time?
That's hard to tell actually. Trying to think
okay, you can say two.
Okay, one would be maybe Lagan, I think, and another maybe Sarkar. I think of these two.
Your favorite city in the whole world?
San Diego, California.
Is it because of the food?
Yeah, well, and next is Mumbai.
Mumbai.
Very close.
Your favorite restaurant?
Usually we go to Mexican and Italian.
And your favorite cuisine is the same?
Yeah, from Mexican, Italian.
And your favorite novel, which you read 10 times?
Oh, I think it's Gandhi's autobiography.
Oh, fantastic. Before we end this thing, I want to ask you a few more questions. What do you feel are the major lacunae in current day technology of echo?
Well, the current lacune is already been there, that we cannot actually look at the whole extent of the coronary arteries. So we can't look at that, those. And also actually, that is the main one. And the other one is that some patients, the echo have very poor windows because they're very big patients, or they have lung problems, so that's the problem. Some of that has been overcome by contrast echocardiography. But I think coronary artery should really be seen by echocardiography very well because they are on the surface of the heart, but they're too near the probe, so we can't see them. But I think the technology is being developed so that we can look at the coronary arteries also.
Another exciting new aspect of echo is handheld echo. How impressed are you with the technology, or what do you feel is the future of handheld echocardiography?
No, I think it really has a great future because you can take the probe, keep it in your pocket, white coat pocket. Anytime you're in the emergency room or in the CCU, someone comes in with a short of breath, you don't know what's going on. You can actually do an echocardiogram on that patient and decide immediately whether he is having cardiac tamponade, he's having cardiac, dissection, or he having poor function. It's very, very useful. Not only that, you can go to rural areas, so you don't have to transport huge machines to the rural areas, and you can take these small machines and make very quick diagnosis. So I think it's very, very useful. The probes are, if you take the one which is something like a cell phone, like the cell phone that you have, iPhone, then the quality is not so good. But if you take one which is something like the size of a small laptop, then the quality is much better. So you can use either of them. And also, it has gone to a stage now that it's not just a cardiologist or some internist or special interest echocardiography using it. Now, practically every physician would be using it in the future. And these small probes, small echo machines, will be used by all. The other day I had someone who was a gastroenterologist come down to me and try to learn echocardiography using the small probe. So it is going to be something, it's just mushroom, that whole field, you know. Yeah.
So if you had a crystal ball, what do you feel are going to be the major advantages in machines and technology in the future, according to you?
I think there are going to be more of artificial intelligence would be introduced, has been introduced already in echocardiogram, but that's going to be more and more, so that when you look at an echocardiogram, machine will be thinking very similar to what you are thinking, and may not be exactly the same. So that will make our work much easier, quicker, so that we will be able to actually, deliver very good care for the patient at the same time in a timely manner. You know.
And finally, what does the future hold for Professor Nanda?
Well,
will you ever stop working, or are you going to go on teaching and spreading echo, the message of echo, all over the world?
Well, I right now don't have any other interest except echocardiography, so that's what I'll keep on doing. Teaching, doing echocardiograms, and clinical examinations like I do now even, and also teaching and spreading and going and lecturing, and I think I'll keep on doing that till the very end.
Thank you, Professor Nanda. It has been a most informative and a beautiful session with Professor Nanda on the past, present and future of echo. Thank you once again, CSI TV 2018.
Thank you, Robin. It's a great pleasure. I'm so excited that I'm meeting you and having a good chat with you here. It's really great.
The pleasure was mine.
Right. I have very fond memories of you and your father.
Thank you, sir.
And your mother.